Good evening, everybody. Professor Najarian, can you hear me?
Yes, loud and clear.
Okay, great. Okay, let me introduce myself. My name is Keelung. I'm the director of the AI Center, AI Research Center at the Chengdu University. But today we are, of course, the forum or the workshop that we have is in the Chengdu Hospital in Keelung in Taipei. I know that you cannot see us, but just for your information that right now we are in the meeting room and we have about 40 to 50 people in the audience. The percentage of the audience, I think more than 50% are medical professionals. Most of them are medical doctors. And also we have professors from various departments from various universities. Some of us are in computer science, computer engineering, data science, bioinformatics, and so we actually have a mixed background, but we are all related to either AI or medical or data science. So you are speaking to the right audience. Okay, so before I give the microphone to you, let me introduce to the audience the speaker for today. So we are very honored to have invited Dr. Kevin Najarian from the University of Michigan. Uh, Dr. Najarian is a professor in the Department of Computational Medicine and Bioinformatics as the main appointment, but he also has joint appointments in the Department of Emergency Medicine and Electrical Engineering and Computer Science. He is also the director of the Biomedical and Clinical Informatics Laboratory and also the associate director of the Well Institute for Clinical Care Research and Innovation. Dr. Najarian received his PhD from University of British Columbia in Canada, and after his PhD, he actually have joined other universities, one from the UNC Charlotte and also in the Virginia Commonwealth. He joined the University of Michigan in 2013, I believe. Okay, and since that he has done wonderful research. He has a lot of funding from NIH and other funding agencies. He has published more than 200 papers. Okay, and he is also the editor and the associate editor for journals. So today we are very happy to have you to come to our workshop. The title of this talk is Challenges and Opportunities of Using AI in Clinical Application. Okay, Dr. Najarian, you have 50 minutes if you want to talk for so long. I know that actually it's very, very late for you, so please just, you can decide how long you want to talk, but we are all ears now. Please, go ahead.
Thank you very much for the kind introduction and many thanks to the organization for inviting me to have a chance to share some of my thoughts with the team. I'm really excited about this opportunity and let's see how far we can go with this idea. So I'm gonna start by let me see my. I'm going to start by thanking our uh, sponsors, people, companies, and organizations that give us money. And by law, I'm required to mention the affiliations and disclose the financial interest that I have in some companies that I'm a co-founder. Some of the ideas that I discuss in this talk may be at least indirectly related to some of the work that these companies are doing. So with that, I'm going to start by showing a diagram that essentially describes what is happening in this very fast changing and evolving field of artificial intelligence, data science, machine learning, deep learning, natural language processing. You'll see that all of these words, all of these fields have significant amount of overlap with each other in terms of the methodology, in terms of the techniques that they're using. And these days is actually very difficult to find one field of data science that is not overlapping with all of these concepts that I've listed in here. So we used to have a lot of like, maybe back in 1950s or 60s, we have a lot of statistical modeling and mechanistic modeling. And these days we are more towards using deep learning and generative AI for different applications. And I will talk about these later on. But this very crowded diagram will tell you how sophisticated and how sort of overlapping all these fields are with respect to each other and challenges that they will cause for it. Speaking of challenges, when government of Canada was starting a new department within Ministry of Health, and that department was tasked to do like identify how AI can help with health and medical applications. They asked me to identify the challenges and opportunities that AI will bring to the field of medicine, and I created a challenge tree for them. And as you can see, this tree has three main branches to it. One is technical challenges, and this is the one that I will be mostly talking about. And some of these challenges are related to the data that are used in medical applications, and some of them focused on algorithmic problems and challenges in the field. Of course, there are two other branches, health and clinical challenges, things that are related to like, ethical issues, legal issues, epistemic sort of, challenges. But we also have a third branch that I elaborated on these things for Government of Canada, and though that branch focuses on cultural, socioeconomic, and policy-related issues that like uh, and I would say that these are perhaps the types of challenges that being more recognized by the community and realize that it's not just a technical issue that we need to address in order to bring AI to bedside. So what I'm gonna do in my talk, I'm gonna elaborate a little bit more on these challenges, technical challenges, talk about specifics of what we have done so far, what we have achieved, and what obstacles we have encountered in the field of AI when it's used for clinical applications. And then hopefully we get to the point that we talk about some of the possible solutions, especially the solutions we have devised in our lab, in our group, and I will share some of those with you. So let's look at, I think, a good place to see what is happening with the status of AI in medicine is to look at the list of approved or cleared AI technologies related to health by Food and Drug Administration, American FDA. And I have a table here that is kind of old. It's from a few months ago. These numbers have a slightly changed, and they're like, a little bit more of those. I think like currently they're around 1,100 basically technologies, AI technologies approved by FDA. At the time that I made this, there were almost like, 900 of them. But regardless of this, like, this data not being the most updated, if you look at the list of uh, different disciplines and the number of AIs that have been approved by FDA for clinical usage, you see that majority of these are in radiology. Look at like, almost 76, 77% of all these technologies are radiology related. And if you look at certain fields like, ear, nose, and throat or GI or like, general hospital, you will see that these technology, there are very few AIs that are actually approved for clinical application. And that's kind of interesting and at the same time concerning. So I'm going to make another observation here that you will see that, like as I mentioned, there are like maybe 1,000 or 1,100 of these technologies have been actually approved for clinical usage. And that's while we are seeing like maybe thousands of papers published every day on AI for medicine. I did an estimation and at some of the literature and some of the uh, basically the list of technologies that have been patented and publications. And it seems that we have practically around uh, 2.5 to about 500,000 technologies that are introduced in publications or in patents. And these are basically AIs for medicine. And each of these patents, each of these publications, they claim that they have addressed an important problem in medicine using AI. But try to think about that number, like something between 300,000 to 600,000, let's say 500,000 technologies. And look at the ones that actually got FDA approval, which is around 1,000. So the question is, why is it that we have so many technologies that people like publish about and get patents on? But when you look at the requirement of getting like FDA approval, regulatory approval to get to clinical side of it, there are very few of them. Like a majority of these technologies, they remain as papers and they get citations and everything, but they will have absolutely no impact on anybody's life. And that is also a major concern that we need to think about. Why is it that we have so few of those technologies that actually make it to the level of like FDA approval or clearance? And as I mentioned, while you see that almost 70, like, 7% of these technologies are radiology related, if you look at other technologies, you see like, in many other fields, like, in pathology, again, the technologies that you see getting approved in pathology, they're image processing related. So many other things that you see on GI are also image processing related. So in other words, despite the fact that we have all kinds of AIs, like and especially these days we have a lot of like large language models. Um, if you look at the things that are actually getting approved and probably used by the community, they're all image related. They're radiology, pathology, or anything, any other field but image processing, which is based on image processing, which is also concerning. And the question is, why is it that the rest of them, they're not getting anywhere? And even more concerning, far more concerning than what we have mentioned, as if we didn't mention a lot of challenges or concerns. But the most concerning issue is that even these technologies that are getting FDA approval, like you were talking about, like 1,100 technologies, only a handful of them are actually used in the clinical setting. Yes, they get patents. Yes, they get FDA approval. But if you look into whether or not these technologies are widely used by clinical community, I would say very few of them, if any, is actually used by clinical community. This FDA approval doesn't mean that the people are actually using them. So that makes it even more interesting. And if you look at the ones that are used, they're actually logistic type AIs. In other words, they're not things related to, for instance, like treatment planning or like, uh, um, uh, medical clinical decision support systems. The ones that are used, truly used, are the ones that are logistic related, like, how to like schedule the operating room, how to better like move the resources from one hospital to another, which are not really clinical decisions. They're affecting clinical uh, decisions, but these are not clinical decisions. These are medical logistic decisions. And those are the AIs that are actually used. That's also like, telling us that there might be some problems that we need to address in order to actually get where we want to go. So with these observations, we want to take a look at some major challenges that has caused this kind of problems. And I have listed some of these challenges. One is that many of these technologies are not properly assessed, validated, and proved by the people who presented to FDA. FDA and other regulatory sort of organizations, they have guidelines as to how to assess the efficacy and safety of these technologies. But in reality, even FDA approval doesn't mean that these technologies are properly assessed, because AIs can do all kinds of like overfitting. They can create unrealistic results that look good on the paper, but they're not generalizable. So that's one major problem. And in another like related problem is that we always have the issue that we call it data drift or auto distribution input, which means that the population that you're dealing with, the people that you are treating, the diseases that you're treating with AI or are assessing with AI, they also change. And the AI that you have used for certain type of distribution of the diseases or patients or pathogens, soon it becomes basically irrelevant, because the problem that you're trying to address has shifted, the data has shifted. So that's another concern. Majority of these papers that you see, I'm going to talk about another issue. If you go look at these technologies and try to reproduce technologies, that's like, another challenge that we are facing. Um, there was a study that they did a few months ago, and they look at a bunch of papers, a significant number of papers that were published in Nature and Science, and they like AI related, and they a team of researchers selected these papers, high quality papers, and they tried to reproduce the results that they were reported in the papers. And it turned out that 80 something, 85% of them are not reproducible at all, in a sense that we're not talking about necessarily dishonesty in reporting like the numbers. It's just that because the way they assess that, because of the way that they have designed the algorithm, these results are like sort of created based on one set of training of the data that can give you like, some good results, and sort of fools you about like, the efficacy and accuracy of these models. But you cannot reproduce them because that was most likely something like a fluke, and it happens a lot with machine learning. The other obstacle that we are facing is transparency of these models. Many of these models, these AI models, especially deep learning models, they're not designed to provide transparency. Nobody knows what is happening in them. And even if you create a very reliable and highly accurate, let's say, neural network, to make a prediction or make a recommendation for clinical action, it is very unlikely that clinicians would rely you, like, you mentioned that majority of the people in the room are clinicians. If I give you a black box that tells you that do this surgery for this person, and that's a patient, like, doesn't need surgery, like they're gonna die, leave them, whatever. If I start looking at black box that is making predictions for you, and there is no justification for these predictions, it is highly unlikely that clinicians, and not just the clinician, regulatory affairs and all those like insurance companies, will not accept the recommendations coming out of a box that nobody knows what's happening in it. So if an AI is going to have any medical use in the clinical setting or even insurance setting, they need to be completely transparent. The people need to know what is happening in them, why they're making this recommendation, and it's based on what the logic. And yet another problem is the issue of privacy. These models, these AI models, machine learning models, they need to be trained with large amounts of data. And the issue of patient privacy does not allow different hospitals to share the data with each other. Often it's very difficult to do that. And if you don't have enough data, then you cannot train your model. But because of the privacy issue, because of like, even intellectual property hidden in the data, entities that have the data are very much reluctant to share the data with each other. So I'm gonna skip the rest of these problems, but because there's a ton of these problems that need to be addressed. What I want to say is that there is clear gap between the papers published in the field and the patents filed by companies and universities and the clinical usage of the ideas discussed in these papers. It's very easy to have a publication that claims things are exactly as written in the paper, but regardless of how good the algorithm is, translation of that technology into clinical setting is a big deal, big problem, big challenge. And if you're asking me that, yes, we know these problems are there, but where is the solution? I would say that the solution is also within AI. So the algorithms, the machine learning algorithms, AI algorithms, have to be further advanced and being helped by other AIs and more thoughtful planning in order to address these challenges to some degree. So um, and that becomes even more significant because of like, the advancements of large language models that they are trained by like looking at patient record. And that privacy issue that I was saying was very significant. Plus, think of the idea, like, if you're using large language models for clinical setting, to some degree you're playing like Russian roulette, which is basically that if you ask the same question twice from ChatGPT immediately, like you ask this question, you give this prompt to ChatGPT, you get the one response, immediately ask the same question and you get a different result. And is that how you want to treat your patients, saying that I use ChatGPT or Llama or whatever to say what treatment should I give you? And like I did it once, it said this drug, and second time it said that drug, or even said like go home, you're fine. So when you're dealing with the models that have uh, lack of robustness, the issue is that how do you want to use them for something as sensitive as medicine? So that's the challenge that we're dealing with. And another challenge that I discussed and I will get back to it is that majority of the times when you want to train reliable machine learning, you need to include the PHI in the data. So you cannot remove like the age of the person. You cannot remove certain like genomic biomarkers. You cannot remove things that define that person. because if you remove them, the model is less accurate. But in order to include it, you hit the wall of privacy of the patient data that nobody wants to give you access to genetic information like about patients all the time. So having said that, that's the pessimistic part of my talk. So I think that I have made my case that there are some challenges and we need to focus on the challenges. Before I continue, would that be possible to mute this, because I guess like I'm hearing my echo through this. I don't know if it's possible to control the echo, it would be easier. So what I'm going to talk about for the rest of this time that I have with you is talking about some of the projects that we have been doing in our lab, and how these projects have been targeting the challenges that I mentioned in the first part of my talk. Remember that we were talking about the issue of transparency and said, like, for medical applications, in order to have um, um, an algorithm that is actually used by clinicians, you need to provide the patients with the logical description of all these recommendations, why these recommendations are made, and why, like, we have a prediction by the mother. How do you make it really transparent? So this project that I'm going to describe here is something that was funded by National Science Foundation, and it is looking at what happens to patients after they're diagnosed with heart failure. So they can go to, like after the diagnosed with heart failure, may like clinicians may decide to do medical therapy, just do, like, medications to them, or they may move the patient to advanced therapy, which will be like giving them LVAD or heart transplant. So basically thinking that medical therapy will not work properly, and then you need to do something mechanical, sort of machine to help with the pumping of the heart, or completely replace the heart, transplant the heart. So this is a very sensitive decision, and I have to say I'm not sure about Taiwan, but in the U.S., such decisions are not just made by the clinicians. There are, like, committees of clinicians, lawyers, representative of faith community, and lay people, just like community people, and they have to look at the patient's data and make that decision. Like if a heart becomes available, they want to recommend that the heart will be given to this person versus that person. That's not an easy thing. And if I create an artificial neural network that comes and make that prediction, say, like, give the heart to this person, not that person, obviously, nobody in that group, including and especially the clinician, will not accept the recommendation that is just based on a black box that nobody knows why is producing these predictions. So, in order to address that, we have created something that, like, it's called tropical geometry-based fuzzy neural network. And this as the name suggests, it has three components. It's a neural network. So just like any other neural networks, it makes a prediction for you based on the, like, training of the data. But it's based on fuzzy logic, in a sense that once you train it, you can actually see the reasoning behind every recommendation, and it has tropical geometry in it, which is one, like, type of mathematical methodology that made these methods more effective. Fuzzy neural networks have been around since 1990s, but the question was, like, there were theoretical mathematical question with the efficacy and the structure of these things that made them sort of, like, people wanted to do, like, more development before they actually use it for real applications. And we use tropical geometry to address some of those challenges. I'm going to, like, discuss this in detail, but it's basically saying making fuzzy logic more suitable for computational sort of operations that we do. I'm not going to discuss the structure of this, but essentially what this model does is basically uh, is initialized with the knowledge of the human user. So unlike regular neural networks that you start from random numbers. In this case, also you can start from random numbers, but you can also initialize it with the knowledge in the field. So in order to initialize that, we interviewed a number of clinicians and we also look at the guidelines that exist in form of like flow charts that they followed by clinical groups. So we use the knowledge, how clinicians actually decide about that. So they look at, the age of the person, they look at certain blood factors and so on. And based on that, there's a rule, for instance, if the person is at that age and the blood factor is that, and sort of, function of the heart is in that range, then we will say that, this person needs advanced therapy like LVAD or transplant. So we collected all of these approximate knowledge, like, the intuitive knowledge from the clinicians and the guidelines that we have. And then we initialize that neural network with that knowledge. We compare the results with when you just initialize it with random numbers, we will see the results. But then once you train the neural network, now those approximate rules that they were intuitive are optimized by the neural network that is trained with the data, real data from the world, right? So those rules may not be very accurate, but after optimizing them using this neurofuzzy model, we have improved rules and also discover new rules that we have not discovered in the past. Like, so maybe clinicians uh, like, they're obviously doing a great job with this, so they know what they're doing, but there might be something that goes undetected. In those cases, some of the rules created by these algorithms are actually doing discovery of new rules, new knowledge about the field. So if you look at the results, we have one column here that says random initialization, and we have another column that says initialize with clinical rules. And as you can see here, in each case, the improvement is significant improvement is achieved when we are instead of initializing with random numbers, we initialize it with the rules that we got from the interviews of clinicians. Like, AU PRC is going up almost like I would say 6-7%. And standard deviation is also going down. So certain thing with F1 score that goes up significantly. So we see that this model creates relatively good results. Like these are around like AUC of around 85%, which is good. But then we want to see this methodology. Is it this transparency that we have achieved with this model? Was it at the cost of losing a lot of accuracy? So we want to have an accurate model that is also transparent. Like we just don't want to kill the transparency for the sake of accuracy. So for that, we went and compared that algorithm with things like random forest, XGBoost, EBM, SVM, and as you can see, we are essentially on par with the best techniques such as like, XGBoost and random forest. We're actually very close, and in most cases, even better than like, the existing other types of machine learning, which is trying to address, and we're still working on these algorithms. We're creating dynamic versions of that. It's like, combination of these ideas with LSTM and other types of, state space models. But in reality, the whole idea is that moving towards more transparent types of algorithms that have a better chance of being actually used in the clinical setting. Um, so the rules coming out of that, for instance, like once you train the neural network, once you're done with it, all the knowledge that is contained in that neural network is a set of rules that clinicians can easily understand. So, it says, for instance, if blood pressure is low and BNP increases, then the patient is eligible for advanced therapy, right? So as simple as that. And there are like, 1, 2, 3, 4, 5, 6 rules that are contained in the neural network that is trained. Now, every time a new patient shows up, some of the one or two of these rules will be fired. It's like, activated. And then you can easily say why the model has made a recommendation for the person. It says it's activated, for instance, this one. This is the reason we are saying, the patient needs to get advanced therapy or not. So that's like, addressing that issue for us. Um, I want to see how much time we have, and I did not anticipate that this would be um um so let me do one more thing. And so I have like probably like I have a ton of the slides left in here. I will do one more project, and I stop and I get uh some questions if you have any questions. So the another issue that I mentioned was that how do we do machine learning when we don't have access to the data? Because hospitals are not very open in sharing the data, and sometimes you have to train the data with PHI, with um, information that identifies the person. There's no way you can leave them out. But how do you want to, like, how can you preserve the privacy of the patient when you're doing that? So that's a big challenge. So that's another project that we've been doing, and we are using something called fully homomorphic encryption, which is like a fancy encryption technique that is based on like some advanced algebraic method. But the idea is that with using that, we can deal with all kinds of sensitive data. So if the data that we're using is low sensitivity, it's not important. You can always like create train a neural network with that. Nobody cares about that. But there are some data that pharmas and healthcare systems, they're not going to share it with anyone because it's super, super, you know, uh, private for them. They're not going to, like, it's intellectual property involvement. They're not going to do that. But there is a spectrum of data that is like because of patient privacy and things like that, they can share it, but they have to be confident that nobody's misusing that. The best way of doing that is encrypting the data. So if I ask a hospital to give me data of their patients, obviously they will be very resistant to doing that. But if they're allowed to completely encrypt the data, and give me encrypted version of the data, obviously they have much less concern about. But the question now becomes, what would be the use of encrypted data? In typical machine learning setting and typical encryption method, once you encrypt the data, you cannot do machine learning on it because order of the data, everything will change. But these fully homomorphic encryption techniques that I mentioned have the capabilities that they they can train the data on the encrypted data. So you can describe the type of encryption, which is called fully homomorphic encryption, provided to the hospitals or um, healthcare system or pharmas. They encrypt the data using the algorithm that you have provided them, and there's a private key there, so only them um, um, can decrypt it. But the way that we have created this algorithm, and the way that we are tuning the machine algorithm will allow us to do encryption of the data. So if we create a bunch of databases, each one of them is encrypted by different uh, private keys. Each of them have different hospital. You can create a secure data hub that is essentially like all the data that is encrypted, you can still, with these algorithms that we're talking about, we can still train a machine learning algorithm and provide like predictions on the encrypted data. These people using these like hospitals or um, pharmas using the private key, they can decrypt the results that the predictions made by that model, and that addresses the issue of privacy. I have to say that we're not the only people doing that. This is something that Microsoft and Google and some universities are working on it. But this method, creating the data, creating the model, and creating even a federated version of that, that people can further train the model with the data that they have and they don't want to share with others, even as an encrypted form. It addresses most of the problems that we have right now, that you either cannot include PHI because they're not shared, or you don't have enough data to train the neural network, right? Or machine learning. That essentially tries to address that problem for us. I think I'm gonna stop here because that's even more than what you gave me for my presentation time. So maybe I stop sharing and I answer any questions that you might have.
Okay, thank you so much, Professor Najarian. Um, so, do we have any question from our audience? If any of you want to ask any question, you can just push the button and the microphone will work. 有没有同仁想要问什么问题？Professor Najarian, I have a question. You,
Absolutely.
you have mentioned that right now most of the FDA-approved technology um, either doesn't include the large language model, or the large language model actually is quite difficult to get approval. Is that correct?
I I have to say that, like, it's not that you cannot get approval for them, but there aren't many of them that is getting approved because of these challenges that I mentioned.
Okay. But we also know that in many of the large hospitals in the United States, they have already started to adopt the chat technology for the medical doctors or the physicians when they are interacting with the patients. So does it mean that if the hospitals are using those technologies, they don't need approval from FDA because it's going to be the hospital's operational, procedure or process?
That's a very good question. And the answer is, the reason that they're using that and the kind of work that they're using that are low level kind of approaches, right? So they're using that for scripting this thing. They're using that to like extract some keywords and things like that, which are very low level, and more importantly, they're not fully automated diagnosis. So they extract some knowledge, they present it to the clinician, and it's the clinician who makes a decision. And um, and not for very important decisions. So they're using that for, like I said, for simple things, mostly towards the logistics of that. For that, they don't need an FDA approval. They can get FDA approval if they want, but they don't necessarily need that. And those are the kind of things that they're using. And I have to add one more item, that majority of the systems that I've seen people using, they're not using that for routine clinical applications. They're using that for research applications because they know that, like, if they get close to um, sort of clinical decision making, if they use this method without FDA approval, they get into really, really big problems, right? So they use it for low-level decisions, mostly logistic decisions that doesn't require any FDA approval, or uh, they're doing that for research, not clinical applications, which is fine. Nobody, like, prevents them from using them for research.
How about the medical insurance companies? Are they using AI to make decisions on the approval of certain medical insurance requests or applications?
They have started looking into that. Yes. And I have to say that I think these, my expectation and like the discussion that I have with colleagues is that the first real applications of these AIs would be for insurance companies and regulatory sort of thing, because they want to assess whether, like, the recommendation, for instance, to do that surgery, was it reasonable or not. Their decision would only affect the financial aspect of that, not the health of the patients in hospital, right? It's a less sensitive thing, and it does not require FDA approval, right? So insurance company can say that I'm just like, any other way of identifying whether they're gonna fund something or not. Right now, an analyst looks at the numbers and say, oh, like, we cannot approve this or we can approve that. They can easily replace that with AI, and that does not have any consequences in terms of FDA approval. So that's why insurance companies may be the first adapters of such technologies moving forward. And I know that some of insurance companies that have been interacting with, they are seriously looking into that, and they're starting like using that for limited kind of things. And but soon they will be using that more heavily for all kinds of decision making on the insurance side.
Okay. Okay. Thank you very much. We have a question here. This is Dr. Wang, a cardiologist, and thank you so much. We enjoyed your talk very much. And I have two quick questions. Since I'm a clinical cardiologist, and the first question is, I think to use machine learning to suggest who should take mechanical circulation support or heart transplantation is very interesting to our clinician. And so I would like to ask, how do you reach the, the decision to do machine learning on this topic? Uh, you you work with heart failure team to make this decision. Uh, this is the first question, and the second question is that we are also trying to use machine learning for some decision making. Um, I see that your models, such as the logistic regression or random forest, and so on, uh, uh, for clinical use, do you suggest which model you like the most? Thank you.
Thank you. Both very good questions. First question is that this project is conducted in collaboration with a number of clinicians, cardiologists, and these cardiologists are the people who are basically doing multiple things. One, creating these initial rules that we use to initialize the neural network. So that's like, they're creating a list of, intuition and intuitive and approximate rules that we use for approximation for initialization of the model. Two, whenever we create an updated rule or a new rule, these are the people who assess that clinically to make sure that these rules are meaningful and not contradictory to the domain knowledge. And three, in the end, these are the people who identify whether what we have created would have any usage setting or not. So basically, if you always make obvious recommendations, like we can only deal with obvious cases, that's no use. Clinicians don't need someone to tell them, like, if the person doesn't have, like, there's no heart rate, there's no pulse, there's no breathing, that person is dead. The algorithm that makes that prediction is basically very correct, but totally useless. So the third task of these clinicians is to see whether these sort of algorithms and these rule bases that we create are actually helpful in clinical setting, and they do something that goes beyond obvious sort of knowledge in the field. So yes, they're heavily involved in that, and we not only the clinicians that we work with, they are compiling the models and the rules that we have, and we share it with larger community, and we get their feedback. So second question that you mentioned is use of logistic regression, random forest, and others. In reality, my tendency, and I guess like, many people like, in AI, the tendency is to use the simplest possible model to address to model a data to basically address the problem. It's not a good idea to jump into the most sophisticated algorithm because like it's easier to publish because people see like some sophisticated acronym for a less known machine learning, which is more complex. It's not a good idea to go for just a just go for too complex a model. Often in many cases, if you want to choose, like if you want to start with a problem, we start with the simplest possible model, something like linear event regression, and then moving to logistic regression, SVM, random forest, and gradually increase the complexity of the model. And whenever we are satisfied with one model, there's no reason to go to the more complex one, because first of all, it is more likely that the more complex models will overfit the data for you. Secondly, like, simpler models are better understandable and explainable compared to the complex ones. So the first level of model that can give you good predictions and reliable performance is the one that you choose, and you normally don't go beyond that. That's the approach that we've been taking in our work.
Okay, I have one last question, which I don't know whether you have any information or not. You have shown us the table that out of the 878 FDA approved AI technology as of July 2024.
Mhm.
Kind of, we are kind of curious whether any of those approved technologies are originated from Taiwan.
I have no idea. I wish I knew the answer for that, but I am hoping that a ton of them. I have no idea, but that's a good question. I look into that.
Okay, okay, great. So this is the homework that we would assign to you, and so that you can let us know that if there's any success story from Taiwan. If not, maybe that some of the people in this room will try to be the first to try to achieve that achievement.
Yeah, one thing I can tell you, like interactions that I have with Chinese with Taiwanese collaborator here, the way that they are uh, designing really effective solutions and the way that they're doing their research, I am confident, even if none of these existing ones are from Taiwan, in the future, many of them will be designed by Taiwanese researchers. So that's something I can assure you.
Okay, and as you know that all the AI chips are produced. The AI chip for the medical technology actually are produced in Taiwan. So you should be able to expect that some of the future medical AI technology will be from Taiwan.
Absolutely. Thank you for, and like I said, the people who invited me for this talk, the intention was to start collaboration with Taiwanese groups, and I look forward to that.
Absolutely. So we would be honored if you have the chance to come to visit Taiwan. We would do our best to make your visit here to be very comfortable and also very productive.